Done. Right. Thank you so much. Good afternoon to one and all present here. Nepal Dietitian Association heartily welcomes everyone to international webinar on holistic approach for diabetes management and care on the occasion of World Diabetes Day, which is November 14, 2021. It has been held every year since 1991. So access to diabetes care is the theme for this year. If not now, then when is the meaning for that aspect. And we have excellent speakers who they are expert in their own field and from different fraternities. So they are Dr. Priyadarshini Yonzon, who is an consultant endocrinologist from Alka Hospital, Jawalakhel, Lalitpur, Nepal. And then we have senior dietitian, Madam Mahendri, NV, registered dietitian as well. She's a former head of the department of CMC Vellore Dietetics department. Then we do have Madam Dietitian Sheryl Salis, registered dietitian. She's founder of Nurture Health Solution from Mumbai. Also, she's a certified diabetes educator. So with that, I'm your coordinator for the day, myself, Dietitian Srividhya Raghunathan Kayastha. I'm a coordinator for Nepal Dietitian Association Pokhara chapter. And with that, without further ado, let me to say, what is NDA? We are always saying Nepal Dietitian Association. What is it actually? Because many might be new and few will be knowing very clearly about that. But Nepal Dietitian Association was established in the year 2010 on 15th January with the initiative of 8 dietitians working in different hospitals of Kathmandu. It is registered under District Development Committee and District Administration Office. It is a non-profitable organization to work for dietitians and nutritionists to safeguard them for their rights and welfare according to the country's law, to draw the attention of the government of Nepal for the provision of dietitian according to the number of beds as amended by the health regulation of government of Nepal, to involve dietitians and nutritionists working in various hospitals and organizations for the reduction, prevention, and management of rapidly growing number of non-communicable diseases and malnutrition in the country. So this is the aim and objective of Nepal Dietitian Association. But let me even tell you how the trainings are happening to organize different types of training, how Nepal Dietitian Association is working, regularly organizing exhibition awareness programs in different hospitals and communities, advocating and even filling the vacancies through advertisement for dietitians in various hospitals and various organizations through government or even non-government, anything, or private, anything. That's how the organization is working. Even CNA is even happening. Even this is a kind of CNA, but it's an awareness program. So help me welcome to open this program. So with a great virtual applause, please help me welcome to invite the President of Nepal Dietitian Association, Madam Senior Dietitian Nani Shova Shakya. Madam, the virtual floor is all yours. Please take the floor.
Thank you. Can you hear me?
Yes, ma'am.
Namaste and good afternoon, everybody. Nepal Dietitian Association is proud to celebrate World Diabetes Day 2021 by organizing this international webinar titled Holistic Approach to Diabetes Management. On behalf of NDA, or Nepal Dietitian Association, I am privileged and honored to welcome all the 3 eminent guest speakers, Dr. Priyadarshini Yonzon, endocrinologist at Alka Hospital Private Limited, Patan, Madam Chief Dietitian Mahendri NV. She is Chief Dietitian and HOD at CMC Vellore. And Dietitian Sheryl Salis, founder of Nurture Health Solutions. And also she is also a diabetic educator, and she is a renowned personality now. So it gives me immense pleasure to welcome all the delegates for today's international webinar. And before I proceed, I just would like to give you a brief scenario of diabetes in world. According to International Diabetes Federation, 463 million adults, or 1 in 11 were living with diabetes in 2019, which is expected to rise to 578 million in 2030. The global prevalence of diabetes have doubled from 4.7 to 8.5% in adult population. Therefore, for the prevention and better management of diabetes, each and everybody should have the access of information regarding healthy diet, physical activity, medication, technology, support, etc., which is not possible by a single person or a single profession. And the access to care is the, I think, theme of this year's World Diabetes Day. And once Steve Jobs once said that greater things are never done by one person, except in exceptional cases. They are done by a team. So to defeat diabetes, we involved in diabetes management should therefore come together. We can't deny the fact that there should be greater success, access to nutrition, education, care, counseling to all people living with diabetes. These are the core component of quality care of diabetes mellitus. Unfortunately, this is not accessible in every healthcare center of Nepal because of government's own initiative and reluctance of our healthcare professionals to involve dietitians, nutritionists in the disease prevention and management. So this webinar will definitely give our fellow dietitians and nutritionists some more vision to take care of diabetic population with approach. Once again, welcome to you all. Thank you. Now I request Dietitian Srividhya to proceed the session. She is coordinator of our Nepal Dietitian Association from Pokhara. Thank you very much. And once again, welcome to you all. So Srividhya.
Thank you, ma'am. Thank you so much. Milanji, can you please highlight me, spotlight me? Yeah. Thank you. World Diabetes Day is the world's largest diabetes awareness campaign and an official United Nations Awareness Day. It was originally launched in 1991. So imagine, we are exactly on 20th year by the International Diabetes Federation and in helping hand of World Health Organization in response to the escalating health threat posed by diabetes. Thousands of local campaigns, activities, screenings, meetings, and events takes place every year on 14th November, and throughout the month, in fact, of the November, these events happen. So, World Diabetes Day's main aim is to make the advocacy efforts to promote diabetes awareness. Not only that, do we know blue circle logo, what it means? It is actually the global symbol for diabetes. It signifies the unity, the global diabetes community in response to the rising number of the people affected by diabetes. So if you want to know the fact even more about that, you can visit www.worlddiabetesday.org. So you will have all the details you require and you can fetch it accordingly. So without further ado, access to diabetes care. So I'm very much interested to know today our section will be of 3 sessions. This one section will be of 3 sessions as we are having 3 speakers as already told in the inception. So access to diabetes care. With that, we have our first speaker. She is having 7+ years of clinical experience as an consultant endocrinologist. She completed her MBBS MD from Tianjin University, China, and she is an consultant endocrinologist. She completed her MD in endocrinology. And she is working currently in Kathmandu Diabetes and Thyroid Center Private Limited, which is in Alka Hospital Private Limited, Jawalakhel, Lalitpur, Kathmandu. She also attended midterm ESI conference in Delhi as a faculty and also a speaker on women in endocrinology. She is also an author and co-author in many national and international journals. So help me welcome one and only Dr. Priyadarshini Yonzon. Dr. Priyadarshini Yonzon, your topic is clinical approach to diabetes management, diabetes mellitus management. Clinical approach to diabetes mellitus management, Dr. Priyadarshini Yonzon. The floor is all yours. Thank you.
Thank you very much, Srividhya ji, for the introduction. And I'm very happy to be here among you today. Thank you to the organizing committee, to Ma'am Nani Shova, the president of NDA, and for giving me this platform. And today is November 13th, which means tomorrow is the World Diabetes Day. So how do I share my slide?
Can you share it? I guess you received, or you want me to share? Yes.
Okay. And how do I change it?
Actually, he will be doing, Dr. Priya.
I'll change it.
Oh, you'll change it for me? Oh, thank you.
Yeah, I'll change it for you.
So I do know that the topic was holistic approach to diabetes management, but since I'm a clinical endocrinologist, so my topic for today will be clinical approach to management of diabetes. But I promise that I will talk very, very less about the pharmacotherapy part of diabetes management. So without wasting any further time, I would like to go on with my presentation. Next slide, please. Okay. So I would like to take you back to 100 years ago. So this is a picture of two very important personalities and scientists who changed the face of diabetes management and who saved millions of lives of people with type 1 diabetes. So in the picture, you can see Sir Frederick Banting, the person wearing the glasses, and with him is his assistant, Charles Best. And both of these individuals were the first people who extracted insulin for therapeutic use. And it was in the year 1921. So we've come a long way. It has been 100 years since the discovery of insulin. And both these individuals, I mean, Sir Frederick Banting received Nobel Prize for his discovery of insulin in 1923. And the birth date of Sir Frederick Banting, which falls on November 15, is also celebrated as the World Diabetes Day. Next slide, please. In the next picture, you can see a toddler, a baby boy. And what is special about this picture is that this was the first individual who received insulin treatment. It was in the year 1922 of January 11th, when Leonard Thompson, who was just 13 years and he lived up to the age of 26 years, where he unfortunately passed away due to pneumonia. So prior to the initiation of insulin therapy, people with type 1 diabetes could only live up to 2 or 3 years at the maximum. So discovery of insulin led to saving millions of lives of people with type 1 diabetes. As we are aware, the incidence of diabetes is increasing at an alarming rate, with an estimated 463 million people living with diabetes. And this number is expected to rise to almost 700 million by the year 2045. And people who have diabetes have type 2 diabetes. Almost 90 to 95% of individuals with diabetes have type 2 diabetes. And type 2 diabetes is a chronic and progressive disease. It is also a complex disease characterized by both insulin resistance and impaired insulin secretion. Next slide, please. So broadly, we can classify diabetes into following categories: type 1 diabetes, autoimmune destruction of beta cells. Beta cells are a special class of cells located in the islet of Langerhans in the pancreas. These cells secrete insulin, and destruction of beta cells leads to absolute insulin deficiency. Diabetes is also classified as type 2 diabetes, which is due to progressive loss of adequate beta cell insulin secretion, frequently on the background of insulin resistance. And we also have specific types of diabetes due to other causes, such as the monogenic diabetes syndromes, such as neonatal diabetes and MODY, diseases of exocrine pancreas, such as cystic fibrosis and pancreatitis, and drug or chemical-induced diabetes, which we also frequently see in clinical practice, such as diabetes or hypogestational diabetes mellitus, which is diagnosed during pregnancy. So I would like to talk briefly about the pathophysiology of type 2 diabetes. So type 2 diabetes, as I mentioned before, it is the result of both insulin resistance and impaired insulin secretion. So the defect is seen at multiple organ level. You can see that at the level of pancreas, there is impaired insulin secretion, increased beta cell apoptosis, decreased beta cell mass, and increased production of glucagon. At the level of liver, we can see insulin resistance, increased hepatic glucose production, insulin resistance at the level of muscles, increased circulating fatty acids, and hyperlipidemia at the level of adipocytes, and impaired incretin effect at the gut. Gut is responsible for releasing gut hormones such as GIP and GLP-1 that help in insulin secretion after oral glucose load. So these are also defective in patients with type 2 diabetes. So talking about the risk factors for diabetes, this is a very simple picture. So there are certain risk factors that cannot be changed, like having a family history of type 2 diabetes. So if one of your parents has diabetes, there is 40% chance that you may get it. And if both parents have type 2 diabetes, the risk increases to 70%. But there are certain modifiable risk factors that you can definitely change. Our eating with the rapid rise in fast food cafes such as KFCs, McDonald's, there is unhealthy eating patterns seen in many individuals. Lifestyle has also become very sedentary. We mostly work from our desk. There is lack of physical activity. There is a lot of long period of time where our body does not get the physical activity that we need. And of course, rapid increase in cases of obesity and overweight. And also there are other risk factors such as previous history of prediabetes, previous history of gestational diabetes mellitus, and certain hormonal conditions such as polycystic ovary syndrome. Diabetes. Next slide, please. So I would like to briefly talk about the diagnosis, the criteria for diagnosis of diabetes. So we can either use the fasting plasma glucose cutoff of more than equal to 126 milligram per deciliter, or we can use the 2-hour plasma glucose of more than or equal to 200 milligram per deciliter after 75 gram OGTT, or we can use HbA1c of equal to or greater than 6.5%, or in a symptomatic patients with typical symptoms of hyperglycemia, such as increased thirst, weight loss, increased polyuria, we can use random blood sugar with a cutoff of 200 milligram per deciliter. So any of the tests can be used for diagnosis of diabetes. How about the diabetes in Nepal? So what we are seeing the picture globally, the burden of diabetes is also increasing at an alarming rate in Nepal. So there was this recent meta-analysis which estimated that the overall prevalence of prediabetes was 9.2% and diabetes was 8.5% in Nepal. What are some of the challenges that we face in diabetes care in Nepal? It is definitely a major healthcare problem. And we see rapid urbanization, unhealthy eating behavior, increasing obesity, stressful lifestyles, sedentary lifestyles, that are all of the contributing factors for the responsible for the rise in cases of type 2 diabetes. And there are also several challenges that we face, including lack of disease awareness among patients, deprived rural healthcare facilities, and definitely high cost of treatment, because diabetes is a chronic disease. So it requires lifelong treatment, and the treatment and blood test, everything is very expensive. And of course, there's more emphasis on communicable diseases. So these are some of the challenges that we are facing in diabetes care in Nepal. So a person who is newly diagnosed with diabetes or pre-diabetes for suggestion or so lifestyle modification is effective in reducing HbA1c of diabetes. But we have to remember that lifestyle modification requires adherence and I would like to show you a picture of our typical Nepalese cuisine. Nepalese people, we love our rice for lunch and dinner. We usually vegetables, some salad and ghee. And for snacks, we love our momos. So these diet are most of the diet in Southeast Asia are very rich in carbohydrate. Next slide, please. So for the majority of people who come with who are diagnosed with diabetes, the most challenging part is how much should we eat, what should we eat, and how to follow a meal plan. So we have to keep in mind their dietary habits, their culture, tradition, family settings, it all. And we also have to remember that because of progressive nature of type 2 diabetes, lifestyle modification may not, but lifestyle changes Next slide, please. So is it possible through diet? This is a very interesting question. Can type 2 diabetes be achieved through diet? So in 2011, there was a study published by researchers in Newcastle University, which showed that an 8-week, 800 was able to achieve remission from diabetes in 7 out of 11 adults that participated. The limitation of this study was that it had a very small sample size, and 6 months after study completion, but applying this to our clinical practice is very difficult. So in this picture, we can see that after putting the patients on a very low calorie diet, there was reduction in plasma blood glucose as earliest as 1 week. You can see that the fasting plasma glucose is decreasing to less than 6 millimole per liter. And there was also fat content, and there was also decrease in hepatic glucose output, and there was normalization of beta cell, which was associated with decreased pancreas and liver fat content. How about weight management? We talk about diet, we also have to talk about weight management, because according to WHO, in the year 2016, 13% of adults were obese and 39% were overweight. And strong and consistent evidence that management of obesity can delay the progression of pre-diabetes to diabetes. So this is a landmark trial, the Diabetes Prevention Program, which was conducted in 27 centers in the US. It was a multi-centric randomized controlled trial where almost they had 5,000 adults, obese adults with pre-diabetes. And what they did was that they separated those individuals into 2 arms. One arm was treated with metformin, and the other arm was treated with intensive lifestyle changes. So in the intensive lifestyle change arm, they had a target weight loss of 7% and physical activity like brisk walking of 150 minutes per week. So at the end of 2 years, what the results showed was that those individuals assigned to the lifestyle change arm had significant reduction in the rate of diabetes diagnosis. So the diagnosis of diabetes was decreased by almost 60% in the lifestyle change arm compared to 31% in the metformin arm. So such kind of programs were also conducted in China, India, Finland. And in China, there was a study called as the Taching study, which showed progression to type 2 diabetes could be prevented even at the end of 11 years in almost 40% of individuals with pre-diabetes. Progression of type 2 diabetes can be delayed by lifestyle changes in pre-diabetic individuals. The next trial, which I'm going to talk briefly about, is the DIRECT trial. So the Diabetes in Remission clinical trial is an ongoing trial which is being conducted in the UK. The aim of this trial was to show that remission of diabetes through weight management. Trial had 149 participants with diabetes of less than 6 years. At the end of 1 year, 46% of participants were in remission and 24% had achieved at least 15 kg of weight loss. And at 24 months, diabetes remission was seen in more than a third adults with diabetes. Of who do not want to go into pharmacotherapy, they just want to have diabetes remission through weight control, diet control. For such individuals, you can recommend weight loss of at least 15 kgs. So having weight loss of 10 to 15 kgs can even be applicable in patients with diabetes, in obese patients with diabetes who do not want to go for pharmacotherapy. Another trial was the Look Ahead trial. This trial was a bit different because it wanted to see if weight loss can have a benefit in cardiovascular morbidity and mortality. So it wanted to see that whether having weight loss can have any positive impact on cardiovascular mortality. So at the end of the trial, even though the cardiovascular benefits were not observed, but various benefits were seen. For example, 50% of participants in the intensive group had lost and maintained more than 5% of their weight, and 27% had maintained more than 10% of their weight at 8 years follow-up. And people in the intensive lifestyle group had positive outcome in lipids, blood pressure, fitness, and mental health. How about physical activity? Of course, we recommend diet, weight management, and we should not forget about physical activity. It remains an integral part of diabetes management. So there are a lot of barriers to physical activity, such as lack of open spaces, especially in a city like Kathmandu. It's very difficult to find open spaces. And the increasing pollution is another problem. So we have to find methods of starting physical activity, like maybe in open spaces such as our terrace, or through video exercises, YouTube exercises. All of these things can be incorporated. So it's never too late for physical activity. So we have to start physical activity today. At every visit, we must encourage our patients to start physical activity. We can start with light walking if the individual has never exercised before. And we should remember to wear comfortable shoes because you don't want your diabetic patients to develop, to get cut wounds, to develop diabetic ulcers. And if exercising alone, if the person has never exercised before, you can exercise with a spouse or friends. And the ADA recommends minimum exercise, moderate intensity exercise, such as brisk walking for 45 minutes per day or 150 minutes per week. Smoking cessation also remains an important part of diabetes counseling, because people with diabetes who smoke have higher risk of cardiovascular disease, premature deaths, microvascular complications, and worse glycemic control compared with non-smokers. And numerous large RCTs have shown benefit of brief counseling, including telephone quit lines in reducing tobacco use. So our diabetic patients to quit smoking. So this algorithm looks a bit complex. So this is the pharmacotherapy for type 2 diabetes management. The first line therapy remains the good old metformin because it is cheap, it is affordable, and it has a good safety profile. It is easily available. But we also have to look at the individual's risk factors, such as if the individual has underlying cardiovascular disease, chronic kidney disease, heart failure. So for such individuals, we have to use drugs that have shown cardiovascular benefit, such as the GLP-1 agonist like liraglutide, or SGLT2 inhibitors such as empagliflozin, and so on. And we also have to take into account the patient's life expectancy, the patient's age, risk of hypoglycemia, patient's weight, And in a country like Nepal, we also have to look at the cost. So if cost is a major issue, we can use affordable drugs such as metformin, sulfonylureas, and TZDs such as pioglitazone. So these are next, I would like to talk about the lean type 2 diabetes, which is a kind of type 2 diabetes, but it is diagnosed in healthy weight adults of BMI less than 25. And studies in developing countries have shown that the clinical characteristics of these patients include history of childhood malnutrition, poor socioeconomic status, early age of onset, and absence of ketosis on withdrawal of insulin. We do get to see a lot of these patients in our practice. Individuals who have type 2 diabetes or who have normal to healthy BMI. So these individuals, there's more male predominance, and there's rapid beta cell failure and impaired insulin secretion. So we can see that in the lean type 2 diabetes, there's early beta cell failure compared to obese type 2 diabetes, and diabetes develops at lower insulin resistance compared to those individuals who are obese and type 2 diabetic. So these are the differences between type 2 diabetes, type 1 diabetes, and ketosis-resistant diabetes of the young, and lean type 2 variant. So the lean type 2 variant diabetes, age of diagnosis is around 40 with male preponderance, and BMI is usually between 18 to 25, and there are no autoantibodies present, and there's 50% family history of diabetes, and insulin sensitivity is normal, but in females might be decreased, are insulin dependent at diagnosis, and the risk of DKA is low in such individuals. How about type 2 diabetes in young adults? So there are, in the last several years, we have seen a lot of cases of type 2 diabetes. So in the today's study, we see that in the youth onset type 2 diabetes, they have very poor response to intensive lifestyle change program compared to adults with type 2 diabetes. And the beta cell function declines by 20 to 35% per year. And response to treatment is also poor. And they progress very rapidly. There's very rapid destruction of beta cells. And type 2 diabetes in young adults are prone to complications at an earlier period compared to their adult counterparts. So this is a rising entity which is of grave concern in diabetes community. So the take-home message from today's presentation is the burden of diabetes is increasing rapidly globally as well as locally. Diabetes is associated with significant mortality and morbidity. Lifestyle changes and weight loss can lead to diabetes remission. However, it is very, very difficult to sustain. And diabetes is a progressive and chronic disease that requires lifelong management with a very good team approach. And with this, I would like to end my presentation. Thank you for your attention.
Thank you so much, Dr. Priyadarshini Yonzon, for your charismatic presentation, which was, we were never able to remove our eyes from your presentation because the points were that way. It was very easily adaptable and it was really you made our day. Thank you so much. Without a further ado, we took many take-homes, and from the take-home, one main thing: does my fingers, all the fingers are of same size? No. Similarly, diet can't be of the same way for everyone. No one can consume the diet which I consume cannot be suitable for others. So simply we can take example of our fingers. So health at every size is required. At the same time, with diabetes, it is very much important to think the aspect of nutrition also. So with the nutrition aspect, now we have our second speaker. She is BSc Human Nutrition graduate from Mysore University in 1975 to 78, with second rank in MSc Food and Nutrition in 1980, and entered the profession of our Nutrition and Dietetics fraternity in the year 1993. She is a succeeded, and she worked more than 23 years in CMC Vellore, that is Christian Medical College Vellore, which is a 2,000 bedded multi-super specialty tertiary care teaching hospital. And she has been the course coordinator for CMC PG Diploma in Dietetics and Dietetic Internship Training from 2001 to 2017, allied health students and nursing and medical students. And also, she was a faculty under CMC NACO, that is National AIDS Control Organization India, for HIV counselors, nurses, doctors, and also mentored many RD interns under IDA. And also, she completely worked for 16 plus years of administrative experience. Also, she got awarded for NIH sponsored project for Garty Grant USA for clinical research projects. And she has research publications and also co-author in many national and international journals. Her diversified interest was even won her poster presentation in various conferences, symposiums, and also in-house competitions. She is Miss Mahendri NV. She was a former or retired head of the Department of Christian Medical College, Vellore, Nutrition and Dietetics Department. And she also was invited for second international conference on food safety and regulatory measures in London on June 6 to 8, 2016. She attended many programs as an author, and she was author and also speaker for many programs, even in IDA, in many chapters. And she also co-authored a chapter, Nutrition Assessment. It was a book. It's a pediatric atlas textbook. So she is a life member of Nutrition Society of India and ISPEN, that is Indian Society of Parenteral and Enteral Nutrition, and Indian Dietetic Association, and also International Association of Dietitians, that is IAD, and Nutrition and Natural Sciences Association, NNHSC. Also, she is an honorary member of Saksham Society, Jaipur. The floor is all yours, ma'am. She is my guru as well, though virtual guru, we haven't met, so you can call me as a Ekalaiva of ma'am. So ma'am, dietitian Mahendri, senior dietitian, the floor is all yours, please.
Yes. Thank you. You can hear me? Yeah. Namaskar, Nepal, and good afternoon to one and all who are joining this session. And I'm in Tumkur. I've retired almost like 4 years ago, but active in my field. I love to learn and share. And next slide, please. I'm very happy to introduce my gurus. Next slide. This is Mrs. Mary Mammon, mother of Indian dietetics, and Sarah Jacob, mother of Indian renal dietetics. Both are my guru. I was like, I worked as their junior colleague almost like 4 years. And above this, my Karma Bhumi, Christian Medical College, Vellore. The tower in the center is the gift of Vellorian for our founder, Ada Skada. Next. Eating right is an integral part of promotion of health as well as preventive health. Managing blood sugar is the key to living well with diabetes, and eating right is the key to managing blood sugar. A diabetes diagnosis does not change a person's food or nutrient needs. Simply put, eat healthy foods in the right amounts at the right times, in addition to consistent amount of carbohydrates on a consistent schedule throughout the day, so that one's blood sugar stays within the target range as much as possible. Registered dietitian nutrition is a health profession qualified to guide the individuals for the diabetes to eat right through MNT. And we are the dietitians, we have to pass on the evidence-based guidelines to the platter of the patient. So the essential components of MNT are like assessment, diagnosis, intervention, monitoring, and evaluate the outcomes. So my focus of the session today is the toughest part, that is intervention. Next slide, please. So please do remember to consult about hydration and vitamin D, because even the mild hydration, like 1 to 2%, can lead to headache and irritability, loss of concentration. But this level, you won't feel thirst. And the best guide for fluid intake is based on calorie intake, that is 1 ml per calorie. And those who work in a hot climate and those who physically exerting activities, they need more fluid. Coming to the vitamin D RDA for adult is 15 microgram. And for Indians, it's just 10 to 30 minutes of sunlight exposure would keep their nutritional status optimum. Otherwise, we have 3 ways to get vitamin D. Apart from sunlight, we can get vitamin D supplement or use the food resource, which are very minimum, but cod liver oil is the best source. Just 1.5 teaspoon of cod liver oil meet your RDA. Next slide, please. Intervention include forming the structured diet plan, meal planning assistance, education, and counseling. The research provides clarity on many food choices and eating patterns that can help people achieve health goals and quality of life. Prioritize planning meals that fits one's health needs, age, gender, activity level, body weight goals, treatment modality, socioeconomic factors, personal factors, preferences, likes, etc. First, assess the barriers present in each individual subject to address them, and then provide an individual with the diabetes the practical tools for day-to-day meal planning, rather than focusing on individual macronutrients, micronutrients, or single foods. Improvising the existing usual eating pattern encourages the joy of eating. Next slide, please. The basic facts. What's the current research input? There is no single diabetes diet or meal plan or diet that is diabetes friendly, that can serve as a correct meal plan for all patients with diabetes, whether it's a type 2 or a gestational or type 1 diabetes, and those with secondary health issues. A dietary pattern that includes carbohydrate from whole grains, legumes, vegetables, and fruits, and low-fat milk is encouraged for good health, as a goal of any meal plan is to achieve and maintain good control over the disease, including control of blood glucose, blood lipid levels, as well as to maintaining a healthy weight and good nutrition. The exact type and times of meals on a diabetic meal plan depend upon individual patient. Eating a high fiber diet can help improve blood cholesterol and blood sugar levels in patients with type 2, or in general, all those with diabetes. Table sugar and alcohol are acceptable in a moderation for many patients with diabetes. Next slide. Most meal plan allows the person with a diabetes to eat the same food as the rest of the family with attention to portion size and timing of meals and snacks. We use this approach because we always insist the patient brings their family member so that they will accept that whatever the diet counseling we have done to do and trust the patient, otherwise they won't do it. Sometimes patient brings their family member for second time counseling. So to do the repeat counseling, as we are always hard pressed for the time, we encourage the patient to bring their one attendant as a family member. And please don't encourage the use of diabetic foods. To say food is diabetic food is now against the law. This is because there isn't any evidence that these foods offer any special benefit over eating healthy. Let the daily diet have as many foods as possible to keep the diet diversity. Some meal planning tools and guidelines include IDAHO plate model, counting carbohydrates, calorie-based diet, food exchange list, food labeling reading, and be prudent. Know all the available tools and the guidelines and use them as appropriate. Meal planning is based on the principles of balanced diet, even for a person with the diabetes, except that it is modified, structured to meet the desired nutrition health goals. A meal plan will tell what to eat, how much to eat, and when to eat. Next slide, please. So this is the tools that we have. And your plate model might be of use those who eat only 3 meals a day, for the low literacy level and elderly. But for Indian patients, it is little difficult, particularly those who eat rice as their staple and refuse to add vegetable. I had many patients, it was difficult to make them complete the plate for the vegetables. They always used to refuse to eat. They eat only rice and the sambar and the rasam, leave out the vegetables. And the carbohydrate counting, the calorie-based meal plans, the bottom two portion, it belongs to the Department of Dietetics. These are the designed by our dietitians. And you can see the carbohydrate is anywhere 63.6 to 67, depending upon the calorie value. Adjacent is the nutrition information. So this serves as a ready reckoner in a planning. Next slide, please. I'm going to hurry up and I'm going to be a little fast because I have very bad throat pain, but I refuse to not to participate in this program because I had promised Vidya. Next slide. Okay, no, okay. Food exchanges is it helps us a lot in our patient group, and these are the tools that we use. We use a standard cup of 200 ml because it's easy for the patient to convert. Half is 100, full is 200, and 1.5 is 150 ml, and 2 is 400 ml. So also the rice, our exchanges, we use 25 grams of cereal because, and the conversion factor from raw to cook is 3. But I insist the patient should check or say, we usually tell, okay, take like 100 grams of rice, cook, and then measure how much is the portion. Now here, like the rice that I use to 1:4 ratio because I use 1 cup of rice and 4 cups of water. So we have to insist the patient how to take, do the exercise of measuring before they adapt these exchanges in their daily life. And next to that is the CMC hospital is the first in India to have started the food exchanges. There are references in some of the American textbook also about this. And you can see that it's so easy. Half cup of group vegetable A, half cup of group vegetable B. And we have listed all the common vegetables that are used in South India. Next slide. Next slide. So now with the revised food composition table data released in 2017, and I'm on a low key. I only attend to the patients, somehow get in contact with me. Recently, for one of my own senior relative family member, I did worked out a food vegetable exchange list. Attached to that, I have placed my vegetable group A, and you can see that, I don't know whether you have experience, whenever we are counseling, we speak about green leafy vegetables, the answer comes from the patient. What is this? Okay. There is no water in a place. You're asking us to eat greens. I know in Tamilnadu, we have 3 greens being used regularly, particularly the drumstick, and we have agathi leaves, we have curry leaves. Please find out what, I know these 3 greens are used in Nepal also. Please find out what are the other greens they are used, and you have to work out your own ready reckoner of exchanger depending upon the vegetables used. You can even use the IFCT, which is available on internet, soft copies, and ready reckoner of high fiber foods. This is again for this patient I had prepared. I have just shared the half the list, not other half list. For the cereals and the pulses, it is 100 gram serving, whereas for nuts, it is 1 ounce or 28 gram. You can see that why we give a high carbohydrate diet, because our diet will have high fiber also. Just eat, including your 2 cereals, millets, but whole gram, we almost meet your 3/4 of your fiber for the day. Next slide, please. So the recommended fiber intake is around 25 to 35 grams, but the soluble fiber 6 to 12 grams per day. And I used to get really irritated when the oats started being a part of a day of many of the patients. Then I started to counter it with our Indian food, that is a Fenugreek Seeds. And if you just go to NIN library, there is loads of research data available way back in 70s and 80s. And Fenugreek Seeds we use in the South India. It is part of a sambar powder. We partly substitute our urad dal with methi seeds, and we use it in a dosa, we use it in a chutney powder, and we even put of it in our curd or buttermilk and consume. So dietary fiber wise, 1 part of Fenugreek seeds is equal to 5 parts of oats, and oats is expensive. And practical tips I usually give to my patient is, when they are introducing the Fenugreek seeds, people do eat it, but it is not with the food. They eat early in the morning. That doesn't help. A fiber to act on the food, it has to be consumed before food or with the food or after food. So I don't encourage a food to be a punishment. Okay, it should be always a joy to eat. So roast the Fenugreek seeds and powder it, because that gives a good aroma and taste. So initially it's 100 grams seeds, powder it, then divide into 10 parts. Half part of 10 is 5 gram. So dosage will be like a 5 gram thrice a day with each meal. Then after 3 days, you increase to 10 gram. Then later 25 gram. That is the maximum dose one can take. And then it's better to divide into the 25 gram into 3 parts, and each part will be around roughly around 8 gram. And you can even put it with even sprinkle it on your salad, it tastes good. Next slide, please. We always are trained and practice food first approach in CMC, because we don't encourage any supplement. And again, for a diabetic, there is no need to give them any supplement unless proven existence of a clinical deficiency. Combining food principle works best for the diabetic diet. And remember, meeting the energy need is the utmost nutrition priority. Next slide, please. Be aware of the barriers and plan wisely. The culture practices, the literacy level, lack of cooking skills, household economy, food insecurity, occupation, place of residence, access to market, poor awareness, etc., etc. Because I used to go to pediatric endocrinology. That was on a Monday, and one of the first famous pediatric endocrinologist, Dr. Raghunathan. I used to fight with them, sir, you are giving a free of cost insulin. But we had one family, 4 daughters, husband absconding, and mother is a housemaid. How will she feed these 4 daughters? So, and sir used to joke, what Mahendri, you want me to be a ration man? I said, you become any man, I don't care, but please make sure that these kids get the food. Okay, just getting them the insulin doesn't help. They need nourishment also. And we have found out that people have got a lot of challenges, and not only maintaining the nourishment, taking care of themselves is also a challenge, and convincing this kind of patient is the greatest challenge for a dietitian. You assist in the goal setting. I'm not for a smart goal. I'm for just 3 simpler taking: why, what, and how, and a when approach. It helps a lot. For me, it makes me easy and so understanding on the patient's side. And consider the comorbidities present while planning the nutrition intervention. Diabetes patients always come with a package of obesity, hypertension, dyslipidemia, CKD, CVD, hyperuricemia. I even had a case 1 or 2 with urea cycle disorder also. Next slide, please. Now, solution building approach rather than problem solving approach is my favorite, because if a person is a poor, am I going to hit my head asking why he's poor? Instead, I'm going to hit my head to find out a way how best I can help this poor person to use his resources best for his health and well-being. So strategies that approach that work in assessing patient. First, from your end, that is lifelong learning approach to update yourself, because as a dietitian, our experience doesn't come in way, but it has to be evidence-based practice like a clinician's. When time is a constraint, prepare a ready reckoners and tables handy. I call it a time-saving approach. When satiety is the deterrent factor, you need to build up a cooking skills and use a volumetric approach. When the money spent on foods can be reallocated, budget replanning approach for cost-effective, sustained, and enhanced nutrition intake. Use diet diversity by adapting different cuisine using the regular foods consumed by the family. So I call it as a borrowing ideas approach. If you are passionate about the profession, then always use caring approach. Find out all possible ways to help the person under your nutrition. And I think you all would have had an experience. I do have many of them very smarties, the Google graduates, or what you call WhatsApp fans, they all come and trouble us. So learn to counter them with your knowledge so that you have an upper hand to stop them bothering you. And be aware what is going on in the internet gurus. So you can expect the question being thrown at you and from these intellectuals. Next slide, please. Coming to volume metric approach. You can see that when you say, okay, you have to eat 2 chapatis made from 50 gram atta with half cup of cooked dal and almost like 2.5 cup of vegetables and milk or curd. Now patient will pull his hair and say, I'm going to die. And in these cases, you can increase the number of, it's the number of chapati that is the problem, not is the whole meal that is there on the plate. So you use a trick, mix all this thing and make a 1 dish pot. So we tried it, and we have, like, I'm missing my exhibitions. It's a jolly time for the entire dietitians, and then we sit and prepare all our displays. The one I put up there on the first masala chapatis from my own exhibition display, and people would love to know, okay, they're very happy. See, from this same ingredients, 50 gram atta, 25 gram dal and vegetables, I can make almost like 5 to 6 chapatis, or you can even make wheat dosha or roti. I've just given you a list of low calorie vegetables, so we can use them. So increase the bulk. It is here, increase the bulk, so the satiety is full, the patient is very happy. And you can even try bisibele bath. That is another Karnataka's the recipe, 1 dish meal. You put all this, you can try, instead of rice, you can try suji to prepare that. This is 2:1 ratio of cereal and dal, and there's a lot of vegetables. It is little watery, but it is very filling. Next slide, please. Subtle bargain, I'm good at it. Because I just put up one example there. People buy mutton 600 rupees worth per kg for a family. Okay, and the cost of protein per gram of your mutton in mutton works around 2.3 to 2.5. That is 2 rupees 50 paisa, whereas the chickpea costs you only 36 to 50 paisa. And almost the nutrient is same. Maybe the chickpea is around 5.6 gram protein less, but added advantage is it's got almost like 12 gram of fiber, a good fiber. So you have to learn. So if they're insisted, you can even convert into eggs. So I mean, that's how you can tell them, like throughout the week, you can get a good source of protein and enjoy even a non-vegetarian food. We most of our patients follow flexitarian diet like this. Monday to Saturday is vegetarian, only a Sunday is their non-vegetarian food. So, and not only that, make sure that they use all edible parts of the food to the maximum. And this jackfruit seeds, I came to know that Nepal do have jackfruit available during season. Make use of the seeds best because they can be used as a substitute for cereal because they got same amount of nutritional profile as that of a cereal. Next slide, please. Now, borrow idea approach. I don't know that we are aware, all cereals can be popped, not only corn. And Shatu is our famous roasted grain flour used in the north, while in the Karnataka, we have a ragi huri hit. We pop the ragi and powder it, and we make it as a porridge or mix with jaggery and ghee and make it as a bowl. And you can do whatever your dishes, you can try it out. And whereas in the coastal Karnataka, during summer, they use the roasted moong. They roast the moong along with little ilachi and put it as a powder. You can mix it with the hot water to make a hot drink or mix it with the cold water as a cold drink. This is called Hesru Kalanir. And and not only that, I even surprised long ago when I went to during summer to one of our relatives' place, they gave me a tilka doodh. I mean, what is it? Gingerly extract as a drink because the yield from their cow is very less, so they use as a milk substitute. And knowingly, people do have a fantastic substitute for their food and drinks, and I think we should tap that resources and make use of to help our people. Next slide, please. All millets can be used as a rice substitute. These are the recipes that we tried out for my case presentation for a London, which I couldn't make it up because my mother fell sick. She was an 18-month-old child with multiple food allergy. She cannot eat rice or wheat, no dals except red gram dal, and no banana, no carrot, no potato, no animal foods. And you should imagine our condition. I'm supposed to provide the diet. I became a chef for 1 week to settle the menu, and that is time we tried varieties of rice because the child is from Andhra. Though she's an 18-year-old, she loves a spicy food. And next is again dal recipe from Karnataka and Andhra. You can see that is on Nuchinunde. It's a steamed dal vada. It is, instead of frying, it is made into steamed ball. Next, adjacent to is called Gurigalu. It's a spicy roasted grams and nuts. We use dry copra. You can skip that part. It's very, it's good for throughout the season, and it can be preserved also. And kosundri is a salad. It's a part of the old. We make it the dosha. And another non-fermented dosa is the peseritu from Andhra Pradesh. I've given the recipe here. All you have to do just is the soak moong, add ginger, green chili, and jeera and salt. Grind it and pour into dosa. Your dosa is ready. Next is dishes from ragi. You call kodo in Nepal. I came to know we make neer dosa and multiple items from ragi. And I am building your recipe database for you. And what I learned it before I preparing the presentation, there are many dishes in Nepal which are akin to what we use in India. For example, your kudo roti is like Tamilnadu adai. In Tamilnadu, they make a thick roti, whereas in Karnataka, we make it very thin roti. And your dodo, how do you pronounce DHDO? It is a ragi mudde in Karnataka. And your
dado, ma'am. It's dado. It's known as dado.
Okay.
We call it as kali in Tamil again.
Your
Kali.
Tamil Nadu, it's a dumpling in English, ragi mudde in Karnataka. And again, the ragi mudde, the Malnad area, they make it so soft, it just melts in the mouth. And then you have a kwati. It has a twin in India, that's a Tamil Nadu. They make a 9 whole grams sundal during Navratri period. And your sel roti, I found out it's a sister of Kodbele of Karnataka. I given it adjacent to it. And Yomari is a modak. And I found out in Bihar, they have a similar version, only the shape is different. You got a beautiful shank jai shape where we make it as a typical modak like shape. There are optimum options of recipes we can teach for the patient. And we do this exercise where for the North Indians, we bring them to our food lab, what we use for our students, and we make them do it and taste it so that they can try it out when they go home. Next. Again, chatumari, your Nepali pizza has 2 Indian dishes. One is neer dosa of Karnataka and then besan dosa. Okay. And only thing is we use coconut and even Assam has got peta, which is similar to neer dosa. I did this exercise in 2016 when I wanted to celebrate World Pulse Day in CMC, only 2 in events from India that year. And I was amazed to see there are so many recipes across India are similar, but we are not aware. Then I said, oh my God, we are connected from Kashmir to Kanyakumari through cuisine, but we fight with each other. Okay, next slide, please. And one more thing, what we have noticed is people waste food. They don't know how to make use of the leftover food, but you can try it out in Tamil Nadu homes. The leftover, or even Karnataka, the rice leftover is not used again as a white rice, but it is turned into a dishes like a lemon rice or fried rice. And also they make it a roti, also idli. And North India, I found out they make a khati roti or khakra. Now you find out how are the seniors are using the leftover rice to make turn into a tasty dish. Next slide, please. Number of meals per day practices are wide varied, and being in CMC, we get people from all over India, even outside India. We found out people from West Bengal eat a maximum number of times, whereas Manipuris eat only twice. The rest of India have 3 meals or 3 + 2 meals. And teachers and bank employees swap the meals, like they have a good amount of breakfast. I mean, usually it is a lunch for breakfast and breakfast for lunch on the weekdays. And the worst kind of meal pattern is observed among the bus conductors, divers, and police personnel. What the current guidelines say, it is again highly individualized, and the gap between meals is 3 to 6 hours, maximum not beyond 6. And better keep the gap between a dinner and bedtime at 3 hours. And next slide, please. I'm already gone to next slides. Next slide. Yeah, I'm super fast. Next slide. Number of meals per day. Achi. Yes, here I am. Okay. Being regular with meal timing is more important. Studies suggest one reason why regular meal times are optimal for your health. They help regulate your body's internal circadian clock. Try to find out what works best to your each individual patient with that cooperation with a little trial and error. ADS, Diabetes Care and Education Specialist recommendations is think of diabetes management as a series of experiments that can help you maximize your self-management. They are not a pass or a fail exercise and don't have a good or a bad judgment associated with them. By experimenting, you learn more about your diabetes and what gets you the results, what you want. Every person is unique, and it's important to identify what works best for each person in terms of meal timing and blood sugar management. Next slide, please. Cook right to eat right. This applies for all of us. It turns out that the food preparation and cooking methods play a major role in a healthy food is for all. Foods that are minimally processed or cooked help to prevent diabetes and lower glucose, control weight, and promote longevity. By contrast, studies have shown that food cooks or processed at high temperatures cause the release of harmful advanced glycation end products and mutagen. Glycated hemoglobin is one such product. Okay, the AGs are compounds that naturally form in our bodies from the chemical reaction of sugar with protein. Heating, grilling, fry roasting has a significant accelerating effect in generation of AGs in food processing. A 10% of ingested AGs is absorbed to the food. Studies, both animal and human, have shown relationship between high dietary AGs intake and oxidative stress, type 2 diabetes, and development of complications. Short heating time, low temperature, high moisture, and pre-exposure to acidified environment can limit AG formation. So that's grains, legumes, fruits, bread, vegetables, milk are the lowest source of AGs unless prepared with added fat. Next slide. Now, there are two sources of AGs. One is exogenous and endogenous food. You can see the sugar will act on the protein and form AGs. When there is an imbalance between these two, and that upsets the homeostasis, and that causes the trouble that leads to increased AG accumulation, accelerated aging process, and earlier disease onset and complication, thus the health disparity. Next slide, please. Teach smart strategies. And you follow yourself too. Take time to chew your food well. This is to get the maximum nutrition from the food you eat, and you focus on what you eat, and you give a time for the brain to even switch on and off the clues and enjoy what you eat, because end of the day, it is the joy of eating that we all have to experience and savor every bite, and avoid stress eating, like eating while you're working, driving, arguing, watching TV, etc., because stress will impair your blood sugar control. Next slide, please. Don't ever miss out educating about a food safety, because however well planned your diet, however nutritious is on the platter, unless the food handling is done properly and consider the food safety, your person is not going to get benefited. Food to keep clean and separate raw and cooked food, cook the food thoroughly, keep the food separate temperature, use a safe water. All these are fundamental principles that have to be informed patient and teach them even how to purchase and how to identify the best produce, etc. That will be part of your counseling. Deliver the best nutri-care to achieve the target. The sound subject knowledge is our strength. Prescription of 8x to increase serum albumin by a doctor was stopped instantly with a sound reasoning on my side. I got so wild when I came to know a patient complaint. Amma, look, a doctor asked me to eat 8 eggs. I got so angry. I said, why are we dietitians inside the hospital? Please, no trespassing. Leave us do our work. All you wanted is to increase the serum albumin. There is a way to do it, not to make the patient eat eggs as a prescription pills. Okay, the continuous professional updating in tune with the changing and revised clinical practice guidelines, and it has to be evidence-based, and lifelong learning helps. Don't give false information. It's okay to accept if you are not sure of the answer. Request for time to get in right information. Like when I joined as an intern in 1993, the recommendation for nephrotic syndrome was 2 grams of protein per kg body weight, but now down the timeline, now it's just 0.8 grams per kg body weight plus the protein lost in the urine. So this updating is required. There is every day new guidelines cropping up, and you have to be aware of it, because even our patients are very smart. They get the information prior they come to your counseling session. Refer professional organization website for getting authentic research-based information and education materials for self and patient education, not and never self-proclaimed professional blogs. I was surprised to see in one of our international blog site, one of the dietitian nutritionist girl had put up an article stating negative calorie foods. Then I didn't want to counter there. I put it on my blog page, say there is no negative calorie food. There cannot be. Till now we have not found out as such a principle or a process occurring in a physiological system. Nepali Dietetic Association can create a learning resource database for the practicing dietitians and recipe bank to cover all the regional variation using different cuisines. As a professional dietitian can disagree to agree, but not to get into an argument with the person. Improve your soft skill and be empathetic. Try to form a community clubs to help each other. A model worked well for rural farmer women, initiated by community health experts from the low-caste healthcare unit CMC Vellore, and this helps in all research post setting. Next slide, please. This is my pet patient because he's a 21-year-old, a special case, my first adult with urea cycle disorder, but the insulin dependent diabetes because of the metabolic complication of his disorder. He got admitted there, and look at the diet that we gave to him was 30 gram protein, 3 gram arginine, rest of them is from carbohydrate and fat. And he just gained from 30 to 38 kgs for his height of 170 centimeter. And he wanted to learn recipes because he cooks well. And I agreed instantly, took him to my students' lab, and then I taught him a rice roti with lots of potato and sagu to make him keep his hunger pang in control. And remember, the amount of carbohydrate intake required for optimal health in human is still unknown. But remember, when you have to, or when you are forced to increase the carbohydrate in the diet of a patient because of the resource limitation, then make sure that every meal has got adequate fiber in the diet so that he will have a good control of his blood sugar level and believe in your and trust to you and follow your diet plan and counsel, and there is a compliance. End of the day, we want our patients to enjoy the effort they put and listening to our diet counseling. Next slide, please. One size does not fit all. You keep saying in every article, but you know this is the core foundation of dietetic principle and the practice, and we recommend individually tailored MNT for every patient. And there is no standard diet, meal timings, meal frequency for adults. Okay, and let's remember everyone is affected differently. Let me use a unique study that's conducted in 2015 by Israeli researchers who followed 800 adults for a week using the same meal pattern, and they found out there is a difference in their glucose values post meal and the spikes. Okay, so they came to conclusion that a variety of factors unique to every person, such as weight, genetics, gut microbe, lifestyle, insulin sensitivity, determine how we respond to different foods. That's the reason why our diet plan has to be customized to each individual. Next slide. To sum up, I used my own slide, which I use for a presentation of MD students. Reduce cereal intake, but use whole grains. Restrict extrinsic simple sugars. Restrict fried foods. Increase use of vegetables to ensure adequate intake of fiber. Eat regular meals. Consume adequate fluids and a balanced diet with varieties of foods from all food groups to add adequate nutrition. Regular exercise to maintain weight. Adequate sunlight exposure for maintaining vitamin D status, or consume foods vitamin D and so. So what we understand is fundamentals never change. So you have to be strong in your physiology, biochemistry, okay, and dietetic, so that you can relate each other whenever you want. Why it happens? how it can be changed. And for that, you need to retrieve your knowledge from these basic subjects. References, I just listed out. There are wonderful references for your recipes. You can, these are all I collected for my 2016 exercise. You can standardize and use it for your database. And the other references, I got a slide. And dear NDN members, I'm on a knowledge transfer mission from 2020 onwards. I did have a wonderful time of almost 7-hour session with the Lucknow dietitians arranged by one of my former students, that is Poonam Tiwari. She is the chief dietitian of one of the hospitals there, but later on COVID came and it stopped, but I continued conducting sessions for not for dietitian, but for public, because I love to share my learning and I want to encourage them to stay for themselves and be better. I believe in sharing the learning as, next slide, please. Next slide. I believe in sharing the learning as one of the most valuable gifts. So as a token of support and encouragement to my junior dietetic friends, I'm happy to share my presentation as small gift to NDA. And that's the reason why I have put so much of content in each slide, because that can be read without a presenter. I have spent my time, you can see that I love arts and I'm an artisan myself, freelance artist. So I like everything that what I do, I have got some artistic touch. And if you are using, please acknowledge it. And so that I want this chain to be continued, share the learning and let it go. And I'm proud to declare that I'm a very passionate, empathetic, caring, patient-pro dietetic professional, glamorous in practice and patient care, not personally. And thank you very much, NDA, and also my Ekalavya Srividhya for giving me this wonderful opportunity to share my learning and a bit of learning for myself. And this is a wonderful quote by Dr. Mahendri. Food is not just calories, it's information. It talks to our DNA and tells it what to do. The most powerful tool to change our health and environment and enter world is our food. Wish you all abundant knowledge and wisdom on efforts for professional recognition practice. Thank you all and wish you all a happy 2022 and hope I'll meet you someday. And excuse me to take leave because I'm not well. My throat is struggling me so bad. So I'm out. All your question and query, please shoot out.
Sure, ma'am. Yeah, sure. Definitely. Thank you. Thank you so much for that wonderful presentation. Though it was little time consuming, but it was definitely very much interesting and more knowledgeable, which is definitely required for our NDA fraternity members and our NDA friends. So without a further ado, dietitians do definitely require practice even in the space of diabetes education, because as comparing with two studies, we came to know like even physiology, biochemistry is definitely needed, because many medications name Dr. Priya was saying, many of our dietitian friends won't be knowing, like the medication name alone, they won't be knowing. So just leave about their group like sulfonylureas, like acarbose, if suppose something is coming. So we need to know about each and every names. So I started my diabetes education in the year 2016, and my guru for diabetes education is none other than Dr. Priyadarshini Yonzon. Then I continued my diabetes education in CMC Vellore in 2017. So we today have a dietitian who is going to speak about diabetes education also. Why dietitian should be a diabetes educator. She is having rich experience of over 20 years in the field of dietetics and diabetes education. Awarded the Finer World Award for Changemaker and Social Media Influencer. She is also a recipient of Alan Drash Fellowship 2021. Course director, visiting faculty and trainer at various educational institutions, associations, and corporate houses. Author of the award-winning book, Diet in Diabetes Simplified. Author, patient, education books like Nutrition Basics and Carbohydrate Counting, ISPAD LFAC, Healthy Eating and Carbohydrate Counting, Family Guide for Mumbai, an initiative of Municipal Corporation of Greater Mumbai. Co-author, Purple Book by FSSAI, chapter on diabetes in the Clinical Dietetics Manual IDA, chapter on nutrition and renal disease in Current Topics in Nutrition Book, chapter on fructose versus sucrose and meal replacement therapy in the RSSDI textbook 2016 and 2020. Selected among 15 people in the world by ISPAD at Boston for special training in research in type 1 diabetes. Features as an expert nutrition on the TV shows Health Mange More and Health Magazine on the Food channel. Regularly contributes articles to print and online media. Speaker at several national international conferences and as publications in peer-reviewed national and international journals to her credit. Presented papers at various international and national conferences and won the first prize at IDCon 2012 and IAOH 2016 for the best oral paper presentation. So help me welcome with a virtual applause to Ms. Sheryl Salis. She is a registered dietitian, certified diabetes educator, insulin pump specialist, sports nutritionist, low FODMAP dietitian, certified onco-nutritionist, founder and director of Nurture Health Solutions, author, Diet in Diabetes Simplified. Role of dietitians as diabetes educators. Sheryl Salis, role of dietitians as diabetes educator. The virtual floor is all yours.
Thank you so much, Srividhya, for that kind introduction and for the invitation as well. I'd like to thank Nepal Dietitian Association, Nani ma'am, you and all the members of Nepal Dietitian Association. It's been a wonderful evening listening to such eminent speakers. And I'm going to give you my perspective, as a diabetes educator practicing for the last 21 years. And honestly, when I started practicing as a diabetes educator, we were just a handful of us in the country. And, a lot of training has been on the job. And today it's wonderful to see so many people venturing into the field of diabetes education. So kindly allow me to share my screen. Can I request for sharing rights? Perfect. Thank you. So I hope my screen is visible and I'm audible. And I started my journey as a diabetes educator. Honestly, it happened by accident. I was a dietitian working with hospitals, and I'm sure the seniors will agree with me. At that point, there was not really a scope for dietitians, and there were very few jobs, and it was very, very difficult. Even for an interview, when we went, we used to have so many of our classmates come for the interview, and getting a job was really, really hard that time. The salaries were really poor, and things have really improved. And I think today there's so much of scope for dietitians, and it's amazing to be, in this area of nutrition and diabetes education at this point of time. And so my journey as a diabetes educator happened by accident because I was offered a job at Novo Nordisk, which is one of the insulin, one of the market leaders in insulin. And that's where I started working as a diabetes educator. And then from there moved on to a hospital, working as a diabetes counselor, counseling people with diabetes, and then moved on to Johnson & Johnson, was heading professional education for West India. And it's been now more than 20 years as a diabetes educator. And it's been a wonderful journey, helping so many people with diabetes improve their quality of life and live a life free of complications. And when I look back at, when I started my journey, there was a general diabetic diet. I'm sure a lot of seniors will agree with me. We used to have cyclostyle sheets where we used to say, okay, 1200 calories, 1400 calories, 1600 calories. So there was a fixed plan that we used to give, and we used to just change the numbers. And there was a big list of no's and a very small list of what can be eaten. And people with diabetes, one is they are not very happy with the diagnosis because food is something that all of us love. And suddenly there's a lot of restriction on food. And then it's like, okay, you can't eat this and you can't eat that. And people used to ask us, should we eat this before food or after food? Because there's hardly anything to eat, because rice was forbidden, mango was forbidden, and a lot of other things were forbidden when it came to diabetes. There was no follow-ups. Honestly, nobody came to a dietitian for follow-up. We used to see the person when they used to be referred to us, and they went back, and we really didn't know if they even followed the plan. Did they comply? Because absolutely no follow-ups, and it was a one-size-fits-all. You come from any part of the country, and the person got the same diet. So if you're a rice-eating person, you were forced to eat chapatis, because that time rice was a forbidden food. And there was no concept of a diabetes educator. So again, when I started out, I think we were just 3 or 4 in the country. And today things have really changed, and changed for the better. So it's no longer a diabetic diet. So there's nothing like a diabetic diet. It's an entire, the entire family follows a healthy eating pattern, and that is more sustainable and something which can be done in the long term. It's not a one size fits all. Like Dr. Priyadarshini rightly said, there's so many different kinds of drugs, so many different kinds of insulins, and every prescription will call for a different meal plan. And therefore it has to be customized. I call it a designer meal plan, because it has to be tailor-made. It's not like my dress will fit somebody else. It has to be tailor-made to fit the person's lifestyle, the preferences, as well as the prescription. It has to be flexible, because we have people having different kinds of job demands. There is somebody who's a teacher having erratic work hours, or maybe a person who's on the field, or a lot of travel involved. And we also have people who work graveyard shifts, like, working through the night, because they're servicing different countries like the US, etc., and therefore having to work in the night. Definitely to personalize to meet individual needs and regional preferences. And diabetes education becomes very important, because diabetes is one such disorder which is lifelong. If you have diabetes, you have to live with it and live happily with it and make friends with it. And for that, you have to manage it well. And therefore, self-diabetes management, or diabetes self-management education, that we call DSME, becomes a very, very important and a crucial role, which a dietitian who's also doubling up as a diabetes educator can do really well. And I'll just tell you about what the terms that we used to use in the past. We used to call it as NIDDM, or non-insulin dependent diabetes mellitus. These words are now become redundant, and we call it type 2 diabetes. IDDM is now type 1 diabetes. So we do not use the words NIDDM or IDDM. It's type 2 diabetes, and it's number 2. And it's type 1 diabetes or number 1 diabetes. It's suffering. I often hear people say, somebody's suffering from diabetes. You are suffering. I don't think we suffer with diabetes. If we manage it well, we live happily, and we really win over diabetes. So it's a living with diabetes. We do not use the word diabetic. We often address people as being diabetic. And ADA has clearly given guidelines that do not use the word diabetic. It is people with diabetes, and they've coined the term as PWD. It's a person with diabetes, or it's people with diabetes. And these are very important things to use when we are consulting patients in our clinic, so that they go back with a very positive messaging about diabetes. We're not diabetic educators, we're diabetes educators, and there's no diabetic diet. It's a meal plan which can be followed by everybody, whether the person has diabetes or doesn't have diabetes. And I think this is very important. And if we are able to, use these terms in our practice, it will really help convey the right messages to our people with diabetes. Now, these are the statistics. In fact, this is Dr. Priyadarshini also spoke about the Nepal diabetes statistics, and this is what is recently published on the IDF Atlas. This is as recent as a couple of days back, and it's live on the website now. And these are what the Nepal diabetes statistics looks like. And yes, India is very, very high in number of people with diabetes and pre-diabetes, but yes, we're also seeing an increasing trend in Nepal as well. Now, when it comes to diabetes, we always say it's a mild disorder, but with serious complications. People with diabetes, especially type 2 diabetes, take their condition very, casually, because they are on medication and they really don't want to go and see a doctor or do their blood glucose test. And often they land up to a doctor's clinic only when they land up with complications. And that's why I say, it's like termites in the wood. You wouldn't really know the damage it has done till you actually see the white powder. And that's when you freak out and then you do some kind of treatment. And therefore, diabetes is very much like that, uncontrolled diabetes. So diabetes, if you keep it under control, your risk of complications is less. But more often than not, people with diabetes are very casual about it, and therefore they land up with uncontrolled diabetes, leading to complications right from head to toe. So you have stroke, you have increased risk for heart disease, neuropathy, even erectile dysfunction is something that we're seeing increasing in people with diabetes, limb amputations as well, and blindness. So therefore, as I say, it's a mild disorder with serious complications. We don't even call it a disease, it's a disorder. And therefore, it is very important that a person with diabetes manages his condition well. And as rightly said by Professor Eliot Jocelyn, the person with diabetes who knows the most will live the longest. And therefore, it is our job as a dietitian, as a diabetes educator, to ensure that we empower our patients with the right information, because there is so much of misinformation which is there available thanks to our, their friends, well-wishers, social media, WhatsApp, that they get confused as to what is the right thing to do. And I really love the saying, which is by an anonymous person who says, if you give a man a fish, you will feed him for a day. But if you teach him how to fish, you will feed him his lifetime. And I think it is so important. And therefore, diabetes self-management education is very, very critical and crucial. Now, when we're looking at diabetes, again, Dr. Priyadarshini covered this very well, that we have different kinds of diabetes. You have type 1 diabetes, you have type 2 diabetes, you have gestational diabetes, and you have so many other types of diabetes. And therefore, we have to first understand the management of it, the nutritional management of it, what are the complications associated with it, what are the targets that are important, and then manage the person with the condition. Now, I'll run you through a few scenarios that we see in our clinic, and these are some of my own people with diabetes. Now, this is a very interesting case, and honestly, in the pandemic, we have seen a lot of children with obesity as well as diabetes. So this was a female, 16-year-old. If you see, she's got acanthosis nigricans. She's 96 kilos. She's obese, working parents. She stays in a nuclear family. Food habits: no breakfast because she's waking up late. Mid-morning is eating something in the canteen or an evening snack. Packaged foods, instant noodles, biscuits, fried snacks. And this is very typical. And I think this is very common in your country as well. Dinner, if food is not tasty, it's ordering in. And a lot of people are ordering in food now because it's very easily accessible. Physical activity is nil. Unlike when we were children, we used to wait to go down to play. Today, you have to force your children to go down to play, because even playing is about being on gadgets. And you have so many different kinds of video games, etc. And she was misdiagnosed as type 1. So honestly, she was misdiagnosed as type 1. And then when we got to know she had actually, type 2 diabetes, she had PCOS as well as high cholesterol levels. And therefore, we had to manage this girl and change her entire lifestyle. And this is becoming a very increasingly common scenario that we're seeing with children, who are as young as 10 years, 12 years, presenting with type 2 diabetes or pre-diabetes with hyperinsulinemia. PCOS has again become another big concern that we're seeing in our girls. This is another case that we've recently had, 29-year-old IT professional. And I think in the recent past, we're seeing a lot of people, and they're actually role models for fitness. They're influencers who are actually promoting fitness and succumbing to cardiac arrest at a very, very early age. So very important is again, so this was again a case, a person with a stressful lifestyle, erratic work hours, smoking 40 cigarettes a day, random blood glucose was 350. And he was a total bit disbelief that he's just 29, how can he get diabetes? And this is another thing. So there is no age, where in the past we used to say people above the age of 60, 65 will get diabetes. But today, I don't think diabetes sees age. It is affecting even the young children to the young adults to, the working population as well as the older people. Now, again, another area where type 1 diabetes and the role of diabetes educators and dietitians becomes very, very crucial is in type 1 diabetes. We have a lot of children now being diagnosed with type 1. Parents are often in denial, and they're always looking for alternative therapies. They feel insulin is an enemy, and the insulin has side effects because that is what is told to them by a lot of their family members and so-called well-wishers. They stop insulin and then they go up, they land up at some quack's clinic or some quack's place, and then they stop insulin. And often they're presented at the hospital in the ICU with diabetes ketoacidosis. So here again, the dietitian and the diabetes educator has a big, big role to play, because we often see, I mean, in spite of us telling the parents, that there is no cure for type 1 diabetes, insulin is a life savior, and this child needs insulin for life. Parents often get carried away by a lot of false promises by these quacks, and often they succumb to these problems, and then people land up with diabetes ketoacidosis in the hospital. Again, gestational diabetes. This is another area, and we're seeing a lot of women today with gestational diabetes, at least in our country. And that is another area where dietitians and diabetes educators can play a big role, because medical nutrition therapy plays a big, big role in management of gestational diabetes. And so if you see the recalls, because pregnancy is one time where women think that, oh, this is the time where I don't have to be worried about fitting into a certain outfit. I can wear loose clothes and eat. And often the parents also think that the person should eat for two. There's a lot of food and there's a lot of carbs and unhealthy food that is consumed during the pregnancy period, as a result of which the person develops gestational diabetes, and then management of gestational diabetes becomes very important. And here, a diabetes educator and a dietitian play a very, very important role. And the good news about gestational diabetes is that most of them can be controlled on lifestyle management alone. So there's a huge potential for dietitians who can also work as diabetes educators, especially in these areas. Now let's see what are the challenges, and I'm sure the challenges are the same in your country as well. With thin fat people, there's cardiodiabetes, metabolic syndrome is a big problem. There's high fat and carb intake, with protein and fiber being a challenge. Poor awareness of the disease. So people do not know. There's a lot of misconceptions and its preventive measures. So often when they get to know they've already landed up with a kidney condition or with some kind of complications, again, the number of endocrinologists in the country compared to the number of people with diabetes is less, and therefore people end up consulting maybe their family physician, who may not have so much knowledge on the recent updates on diabetes management. Time constraints, poor doctor to patient ratio, late diagnosis leading to irreversible damage. Sometimes we have people who've been having diabetes for a long period of time and they do not test. And that's why in India today, we are actually pushing the government to screen people at the age of 25. So today we're looking at screening people for diabetes at the age of 25, because we're seeing that it is catching on very early. Barrier to insulin therapy. And I'm sure this concern is there across the country, because everywhere this is an issue. People think that insulin means my one leg is in the grave. If the doctor has put me on insulin, I will change the doctor, go to another doctor and tell the doctor, I was prescribed insulin and that's why I'm not going to that doctor. When they do not understand that actually insulin is good. And sometimes early initiation of insulin actually helps to preserve the beta cells. Health insurance does not cover certain conditions, and complications are in the expense. So very important is the kind of expense and out of pocket that the poor people have to spend, whether it's for doctor fees, whether it's for insulin or for medication or for blood glucose testing. Everything requires person to spend out of their pocket, and therefore compliance again deteriorates. Now, when we're looking at a diabetes care team, every person in the diabetes care team is very, very important, because the person needs motivation, education, and discipline, and therefore creating a right environment to help the person achieve good metabolic control and improved health. And therefore the diabetes educator or the dietitian who's doubling up as a diabetes educator plays a very crucial role. I always say they play a link, or they bridge the gap between the doctor and the person with diabetes, because they are spending more time with the person. They understand the challenges. They know exactly what is the challenge that the person is encountering, and then maybe go and convey it to the doctor, and then work as a team to help the person, keeping the person as the center and helping the person achieve their goals and living a good quality life with diabetes. So therefore, very important is to have evidence-based approach. And this is something I think we all need to do, is because there's so much of advancement in nutrition science. So from where we used to tell people what not to eat and what to eat, to today telling people how much to eat, when to eat, and what to eat, I think things have really changed. Even in terms of diabetes management, there's been a paradigm shift in terms of medications and technology, and therefore we have to be very updated with the recent advances in diabetes management. Now, when we're looking at glycemic recommendations, there are targets that are set, but again, they're not set on stone, and therefore it has to be individualized. For example, you have somebody living alone at home who's a senior person, and again, at a risk of maybe hypoglycemia, the targets could be slightly higher. If it's a child who's repeatedly going into hypoglycemia, you may want to set the targets to be higher to prevent hypoglycemia unawareness. In gestational diabetes, the targets are very tight because you want to ensure that the pregnancy outcomes are very good. And therefore the targets would change, and therefore it's not a one size fits all, and it is tailor-made. And today we're looking at personalized nutrition. We're looking at personalized diabetes education. I think this is really coming up in a big way. Again, a person could have a good BMI, but have more body fat. And we know that in diabetes, it is visceral obesity, it's adiposity, which is actually the problem. And therefore today now, when we're looking at BMI, the new thing is waist to height ratio and also the waist circumference. So abdominal circumference or abdominal adiposity is very, very important factors to consider when we're looking at diabetes or any kind of non-communicable disease or lifestyle diseases. Now, I think Dr. Mahendri man really did a good job when it comes to the diet part. First we have the food pyramid, and now it's very simple. It's the food plate. So ADA has made it very simple. It's like, instead of taking a 12-inch plate, take a 9-inch plate, fill half your plate with non-starchy vegetables, 1/4 of your plate with cereals, millets, and starchy vegetables, and 1/4 of your plate with protein-rich foods. By doing this, you're not only moderating the carbs, but you're also making the meal nutrient dense, and you're watching the portions. And therefore take a 9-inch plate. So you're ensuring portion control with emphasis on nutrient quality. And that is important. So teaching the person what is the right way to fill your plate, as well as how much to eat, I think is very crucial. Now, Dr. Priyadarshini also covered about diabetes remission. And a lot of people are now promoting it as diabetes reversal. But if the person goes back to their regular lifestyle, it is possible for a re-reversal to happen. And therefore the right term to use is remission. And if you see a person who's newly diagnosed with type 2 diabetes, or if the person is having pre-diabetes, then this person is the right candidate to consider for diabetes remission. And today we have a lot of evidence to show that if you are able to put the person on a low calorie diet, and ADA also says you can use meal replacers if required, it can help to get the person into diabetes remission. Again, this is a huge area, and that's why I feel we dietitians play a very, very crucial role in terms of preventive medicine. And I think each one of us is a preventive diabetologist, a preventive cardiologist, a preventive nephrologist, and you say any prevention of any kind of serious complication. And I think that is something that we have to take our role very seriously and help people with pre-diabetes, prevent them from getting diabetes or delay the onset of diabetes, and somebody with diabetes preventing complications. Because often nephrologists feel very upset because by the time the person actually lands up at their clinic, the person's creatinine is already at that level where very little can be done in terms of prevention. And therefore, we have to play this role of a preventive specialist to a very, very high level of degree. Again, when it comes to exercise, and I'm guilty of the fact, honestly, 20 years back, I used to say, or even 15 years back, I used to say brisk walking 45 minutes daily for every person who came to me with diabetes. Everybody got the same prescription when it came to exercise. And today we know that all exercises will have a different impact on blood glucose levels. Anaerobic activity versus aerobic activity, even yoga. A lot of people are doing yoga, but we are seeing with yoga also blood glucose levels rise, especially in type 1s. So exercise also has to be personalized, and it's not a one size fits all. For example, somebody's got nephropathy or somebody's got retinopathy. Doing any kind of high intensity interval training or maybe weightlifting or jumping, skipping is only going to worsen the condition. Somebody with a foot amputation, the best thing is to do is offload your foot, or with any foot problem. So therefore, exercise has to be also tailor-made. It cannot be a one size fits all approach. And therefore, brisk walking for 45 minutes every day is not something that can be generalized to every person with diabetes, because every exercise will need a different level of management when it comes to blood glucose or it comes to your nutrition. Now, drugs, like Srividhya rightly said, honestly, when we started again 20 years back, we just had metformin, we had sulfonylureas, and we had alpha glucosidase inhibitors. And today you have a basket of different kinds of drugs, so many different kinds of drugs with so many different kinds of side effects, as well as what is the time. So I think, again, an educator's job is more to do is, one is look at the side effects. Somebody who's got IBS, if the person is going to be on alpha glucosidase inhibitor, he's not going to be feeling comfortable. Somebody who's on a low carb diet and the person is on sulfonylureas, or the person is on insulin, or the person is on alpha glucosidase inhibitors, it's going to cause severe hypoglycemia. So very, very important is to look at what drug the person is on. And there could be so many brand names. But today you have a lot of apps which actually tell you what is the generic name of the drug. So understand that. If the person is on an SGLT2 inhibitor, now it flushes out glucose in the urine. So very important guideline to give is that you need to drink a lot of water. You have to ensure personal hygiene because the person can have recurrent UTIs, and you cannot be on a very, very low carb diet. And this is not what I'm saying. This is what the ADA guidelines say. If somebody is on an alpha glucosidase inhibitor, and if you want to treat hypoglycemia, then the way to treat hypoglycemia is not by giving sugar, but by giving glucose. So as small as that, the kind of advice. Also, what time to take. I've got people who've had diabetes for 10 years taking all the medicine at one time because it's easy. I forget otherwise. But it doesn't work like that. There are some medicines which need to be taken 20 minutes before. Maybe some need to be taken just before the meal. So it's again, very, very important. And therefore, knowing the side effects. Sometimes with pioglitazones, the person gains a lot of weight and they're wondering, why am I gaining weight? And it is only because the person is on this drug, which actually causes a lot of water retention. So look at those things, look at the kidney profile. And if you feel that there is something amiss, please go and discuss with the doctor. And I think today endocrinologists are really happy to discuss because they're all working for the benefit of the person with diabetes. I've had cases with metformin. Now, metformin is the most simplest drug, which is even given for PCOS. But we've had people with severe diarrhea with metformin. So if you see that, because they feel that, oh, I've started a diet and that's why I'm having diarrhea. But no, it could be because of metformin. Look for B12 deficiency with metformin. And there is so much to talk when it comes to drugs, but therefore it cannot be a one size fits all. Look at the prescription and then tailor make the plan according to the prescription. Insulin. Again, I worked with Novo Nordisk, which was one of the market leaders in insulin in 2000. And that time we used to just have short acting insulin, we had intermediate acting insulin, and we had a premix insulin, like a 30/70. Today you have again a big range of insulins. You have fast acting insulin, you have rapid acting insulin, you have an intermediate acting insulin, you have a long acting insulin, you have a premix analog insulin, and you have your premix conventional insulin. Again, every insulin prescription will call for a different meal plan, will call for a different advice when it comes to meal planning, hypoglycemia management, etc. And therefore, it's not a one size fits all. So we have to know the insulins in terms of the onset of action, how much before the meal should the person take it? What is the peak profile? Am I giving enough adequate carbs at that time? What is the duration of action? Can I take 2 insulins within a gap of 4 hours? Will there be insulin stacking? Will the person go into hypo? If the person is not eating enough, do I need to give so much insulin? So all these are very, very important factors. And therefore, we need to understand and know insulins, the action, the peak profile, as well as the duration of action. Again, there's a misconception among most people with diabetes. They feel that if I'm on insulin or if I have diabetes, I should eat every 3 hours. Is it true? Not really. Again, it depends on the person's prescription in terms of what drugs is the person is on, what insulin is the person is on. And therefore, it has to be customized to meet the lifestyle of the person with diabetes and which drugs or insulin the person is on. And therefore, carbohydrate counting comes into play, especially when it comes to type 1 diabetes. Am I syncing my insulin with the meal? Am I taking the right amount of insulin? For example, I'm eating, the child is not feeling hungry, wants to eat 1 chapati less, or maybe 1 cup of rice less. If I give the same amount of insulin, the child will go into hypoglycemia post-meal. So do I need to give less or do I need to give more? Is what we will understand when we do carbohydrate counting. And I think today, the West has moved far ahead. In fact, they are doing protein and fat counting. So therefore, it's very, very important to manage type 1s by doing carb counting at diagnosis itself. So you look at the type of insulin the person is on, and then you can do carbohydrate counting, arrive at an insulin to carb ratio, and then plan the meals accordingly, whether it is your breakfast, your mid-meal snacks. Does every person on insulin need a bedtime snack? Not necessarily. For example, if somebody is on a fast-acting insulin or a rapid-acting insulin at dinner, it does not call for a bedtime snack. But if there is somebody who's on a regular-acting insulin and maybe an NPH, then yes, a bedtime snack becomes mandatory. And therefore, it's not a one-size-fits-all approach. So I hope I'm trying to convey the right message that everything will require a lot of customization and it's personalization that is very important. We have SMBG. In fact, again, when I look back 20 years back, not everybody had a glucose monitor because it was very expensive. They used to get it from the US for 7,000 rupees at that time. And today you have glucose monitors, which are more reasonable. So we ask our people with diabetes to test more frequently. maintain logbooks. Today you have different apps and each company has their own apps. So look at the trends. So we can look at different blood glucose, readings, and then understand what is the impact of meal, what is the impact of exercise. Sleep has a very big impact, which we sometimes don't consider. And I think today in the pandemic, it's very, very important to consider sleep because people are anxious, there's uncertainty, there's a lot of anxiety, and there's insomnia. So people are not sleeping well. And as a result of which, that is also impacting their blood glucose levels. Stress plays a huge role. So look at all the factors. It's not only meal. You can't look at it only as, in silos. You have to look at the entire picture and then understand what is actually impacting the person's glucose. Maybe a fight with the spouse, maybe a fight with the boss, maybe pressures of sales. There could be so many factors which are impacting the glucose levels. Even insulin delivery devices, right from having those glass syringes where they used to boil the syringes and then use it, to now having the plastic syringes, to the pens, to now the more advanced insulin pumps. Again, because I think in now your country and our country, it's very similar that, insulin pumps is something that they have to pay out of pocket. It's expensive and not too many of our people are on insulin pumps. But if you look at the other countries, insulin pumps are provided free of cost to people with diabetes, especially type 1s who are on insulin within 6 months of diagnosis. So there we have a large population of people with insulin pumps. In our countries, we have fewer number. But again, this is another area where we can play a huge role in terms of counseling people on how to use. Maybe you don't have too many people, but it's important to be aware because they go or they have relatives abroad, they learn about it. Today, thanks to, Dr. Google, they get a lot of information. And if you do not know, it looks like, oh my God, she doesn't know anything. Again, about insulin techniques, I think here, again, a role of an educator plays a very, very important role on what is the right way to take insulin. How do I prevent lipohypertrophies? How do I check for it? Because sometimes a person is taking insulin and sugars are not coming under control. What could be the reason? It could be a lipo, that the child is injecting insulin at the same spot. And as a result of which there's lipohypertrophy, and therefore the insulin is not going into the body. Insulin storage. I've had a patient recently who called me up and said, my maid by mistake has put 5 cartridges of Lantus in the freezer. Can I use it? I said, no, I'm sorry, you'll have to discard it. Because if you put Lantus in the freezer, you can't use it. Or you're at high temperatures. Again, the insulin potency reduces. So very, very important things in terms of how to store insulin, what is the right way to give insulin, how do I follow the site rotation? And I think here again, we play a very, very big role. Today from SMBG, first we used to actually hospitalize people for CGMS. Today, CGMS has become a big, big boon in our country. And I'm sure even you all are using it. And today we're talking about HbA1c, because HbA1c is an average of highs and lows. So person, when a person comes to me with an HbA1c of 5.5, person is very happy, but I'm a little worried because I'm looking at how many hypos has this person had. Because a person could have a blood glucose level of 40 and then 400. So he's actually having a lot of glycemic variability. But an HbA1c of 5.5, 6, 6.5, excellent. But that is not good control. And therefore, we are moving from HbA1c to something called as time in range. Time in range is that how much time of the day is my blood glucose levels in the desired target range that I have set. Again, the time in range or the target range can be different for different people. And at least 70% of the time in most people, if they are in range, that means they are in good glucose. Their glycemic control is good. And therefore, today we are talking about time in range, we're talking about time above range, we're talking about time below range. So this is a very, very new concept. In fact, when I went to Boston a couple of years back, everybody was talking only time in range. And here I was trying to say even HbA1c is expensive for our patients. For us to get our patients to do HbA1c maybe every 3 months is difficult. But there, all their patients are on CGMS and they are only looking at time in range. Now, when you're looking at continuous glucose monitoring system, so CGMS is continuous glucose monitoring system, you may have a person who's doing the pre-lunch and the pre-dinner, and it is coming in the absolute normal range. So he's reporting his pre-lunch, he's reporting pre-dinner, and we know our patients. The moment they have to go and do a blood test, 1 week prior, they will stop rice, they will start having bitter gourd juice, they'll do all the diet control. For them, it's a report card which they have to show their doctor. Doctor is happy, they are happy, they're back to square one. They don't understand that they're actually cheating themselves. But when you do a CGMS, it actually tells you what's happening in between, what's happening through the night. So it gives you a clear picture of how the glucose is through the day and the night. So basically it gives you good glucose trends. And this is a glucose trend of one of our patients. And if you see, most of the time the person has been in range. Now with CGMS, sometimes we see that, because it is measuring interstitial fluid. So when it shows low, we tell the person, don't just rely on CGMS. Do your finger prick. Check the blood glucose on the glucose monitor. Because sometimes it can show low on the CGMS, but it can be normal on the glucose monitor. So always test when in doubt. And therefore having a meter or a blood glucose monitoring device is extremely important. Now, this is an interesting case of one of our children who was referred to us. If you see 165 centimeters, 62 kilos, fasting was 280, postprandial 356, absolutely out of range. None of his glucose readings were in range. HbA1c was 13.2. And just by education, we didn't obviously, we have to gradually bring it down. Bringing it down from a 400 to 100 just at once is not good. It has to be very gradual. And we were able to bring it down to 8.2 in 4 months. And the person was on insulin pump. And therefore, CGMS really helps us understand. And if you look at the insulin dosage as well, he was on 116 units and we got it down to around 60 units of insulin. Now, another role where an educator plays a very, very important part is in hypoglycemia management, especially when a person is on insulin, a person is on sulfonylureas. Hypoglycemia can happen. And therefore, educating the person right at the time when we're counseling them is very important. What to do? Because they know, okay, now I've got high blood glucose. Suddenly I'm feeling uncomfortable. I'm sweaty. I'm at a party or, I'm out and I'm feeling very faintish. The relatives need to know what to do, especially if they are in moderate or severe hypoglycemia. What is the right treatment? Does everybody need 15 grams of glucose? No, it is 0.3 grams per kg body weight is the amount of glucose that the person needs to consume. So again, hypoglycemia management, keeping the hypo treatment kit with them. Today you have hypo tablets, you have lozenges, a blood glucose monitoring device is again very, very important. And then for children, we have glucagon injections also that we ask them to keep. Hyperglycemia. My blood glucose is running high through the day. What do I do? I'm feeling very, very unwell. So these are important things. Obviously, they're going to consult their endocrinologist, but in case they don't get to their endocrinologist, what can I do if my blood glucose is running high? So we as educators and dietitians, we can tell them, okay, I have salted fluids, make sure you drink adequate liquid, make sure you have adequate water, because remember, when glucose is high, our body becomes dry. It's a high and dry situation. So therefore, hydration is very, very crucial when it comes to hypoglycemia and management of hypoglycemia. Keep checking the blood glucose levels and rush to your doctor or to the hospital as soon as possible. Checking for ketones. And therefore, every person, at least with type 1 diabetes, should have a ketone strips with them. Talk to them about exercise guidelines. Some people think, oh, my blood glucose is 250. I'll go for a nice run or a jog and I'll come back. What will happen? More ketosis. And therefore, we know that high blood glucose levels or low blood glucose levels, avoid exercising. Bring them to the normal levels and then exercise. And this is something which we need to communicate to our patients. Sick day management. Somebody who's having a sick day is unwell, maybe having diarrhea or maybe having some infection. Sugars are running high. Therefore, what do I do at that time? Check blood glucose levels. Hydrate. Make sure the person is having some food because the person doesn't have appetite. Look at what it is. Are the sugars high? Are the sugars low? How do I manage? Travel, because today you have people traveling across the globe. So what do I need to do if I'm having diabetes? What do I take? In fact, in the COVID situation, so many people were stuck abroad and it's not easy to get prescription medications. So again, always carry extra supplies. So suppose you're going for 3 months, maybe carry 4 months supplies, maybe carry 5 months supplies. Always keep some amount of, your medication in your hand luggage. Sometimes you go, your bag is lost and then you're stuck in a foreign country not knowing what to do. I've had a person who was in an insulin pump and she was in a not a waterproof insulin pump. She jumped into the pool out of excitement. And then the parents were calling me out frantically from Singapore saying, I don't know what to do because we don't know any doctor here. And the girl's insulin pump has stopped working. So what do you do? She did not remember the insulin dosages as well. And she was from Dubai. She didn't know, how, she could not reach her doctor. So these are situations that can arise. Very, very important is pregnancy. Somebody who's already got diabetes or has type 1 diabetes or even type 2 or somebody who's PCOS. Very important is to ensure, especially if they have diabetes, that their blood glucose levels have to be in the normal range when they conceive. And then throughout pregnancy management, suppose they have gestational diabetes, how do you manage the condition? Because nutrition becomes very, very different when it comes to GDM. When we are talking about a heavy breakfast in GDM, we talk about splitting the breakfast, splitting the meal, giving low glycemic index, low glycemic load meals at breakfast, and ensuring that the postprandial, because here we are looking at 1 hourly postprandial blood glucose levels. And therefore making sure that they are in the range. Again, the range, the target is very, very tight when it comes to pregnancy, because we're looking at good positive health outcomes, not only for the mother, but also for the baby. We want to prevent macrosomia. We want to prevent big babies. We want to prevent any complications arising because of gestational diabetes or high blood glucose levels. Post-delivery counseling, because the mother is now delivered, especially if she is already having diabetes, she's type 1. And then remember, lactation is a high energy expense procedure. So before lactation, she has to ensure she drinks water, she has some carbohydrate snack, because otherwise she'll go into hypoglycemia post feeding the baby. So again, this counseling becomes very, very crucial. And in pregnancy, I'm telling you, they are the best patients, because they're very compliant, because they know that if they keep their glucose under control, only then will they have good, their baby is very important to them. So they will do anything that you tell them to do. Last few slides. This is a very interesting case again, because this is something that we see with diabetes. 50-year-old male with uncontrolled diabetes, previous history of ulcer, and this is actually somebody I know very closely. He's had a minor bike accident, hurt the middle toe of his right foot. He did not even bother about it. There was no pain. What happened is he had fever with chills, severe fever with chills, going to the local GP, blood glucose levels are high, GP tests him for malaria, dengue, etc. Toe area blackened, white discharge from the area. Local surgeon, because he wanted to save money, as they say, penny wise, pound foolish. So he went to a local surgeon, kept doing the dressings, and then by the time he was, referred to a foot surgeon, he lost his digits of his foot. And therefore, it is very important in diabetes, especially uncontrolled diabetes. Foot care becomes very important. As they say, that if you want to look good, you keep looking at your face, you take care of your face. But for a person with diabetes, foot care becomes a very, very important part of his diabetes management. And this person could have actually, because then he could not walk. He gained so much weight, and unfortunately, he's passed away now. So remember, give an inch to a diabetes foot, and the problem, and it will take a foot. And diabetes foot is preventable. And again, we have a role here as educators that we can actually, because most people, when they come to the clinic, please look at their footwear. They do not wear the right footwear, and footwear becomes very important in diabetes. How do they take care of their feet? How do they, wash their feet? How do they wipe their feet? Do they wipe the interspaces of their web spaces? All these are important things. What are they treating their foot to? Sometimes they walk on very, very hot surfaces and they get foot burn, or they're walking, we recently had a lawyer, he's a divorce lawyer, very busy, very stressed because of the divorce rates going so high blood glucose levels, was walking on grass because somebody told him, if you want to keep your mind calm, walk on grass barefoot. He walked on grass barefoot, severe neuropathy, absolutely had no idea, came home, rubbed his feet on the doormat, and it was fully drenched with blood. And therefore, very important is to give, because if we do not look at the person's foot, he will not know that it is important to check the feet and to take care of the feet. So look at the footwear. Sometimes he asks the person to remove the footwear outside the clinic, but very important is to check what footwear. Sometimes they're wearing plastic or they're wearing very fancy shoes, which are not diabetes friendly. So a stitch in time saves 9, and it is our role again to prevent a diabetic foot amputation. So for all the approaches, I think most important is patient education, and key is education, keeping the HbA1c under control, offloading. If anybody has a problem, if he's got a hurt on his foot, offload it. Do not walk on it. It is only going to get worsened. So again, exercise has to be very, very customized and specific. Again, reminding the person for timely investigations, checking the creatinine level, because by the time the person comes and if he gets to see his creatinine is 2, there's very little that you can do. But if you see the creatinine hovering around 1, 1.1, that is somewhere where we can play a role and actually help to prevent the progression to kidney disease. And therefore, very important is to remind them for routine examinations, whether it's eye examination. And again, when it comes to eye examination, we see people going to an optician. They have to go to an ophthalmologist. They have to do a proper, fundoscopy to see whether there is any change in the retina. And these are important things. And sometimes these things, the complications start setting in even before the person gets to know that they have diabetes. And therefore, it is upon the person and it's upon us to help prevent the person from getting any of these kind of health, complications, whether it's blindness, heart disease, kidney disease, impotency, and amputation. And thank you so much for your patient hearing. I think whatever I've spoken is in my book, Diet and Diabetes Simplified, and I'll be happy to answer any questions. I hope I haven't exceeded time, Srividhya.
Thank you. Thank you so much, Sheryl. That was really informative. I guess you covered everything. Since being diabetes educator here, Mahendri ma'am is also a diabetes educator. Maybe you'll be knowing because she is from CMC Vellore. And I'm also being a diabetes educator. So I can understand maybe for new diabetes educators or who are emerging or who want to learn about that, maybe have a state of ambiguity, but definitely we can address that and we can do together with this. NDA will definitely help the fraternity members. So without further ado, I already have made this thing in the chat that everyone can, if you have any questions, we are ready to answer, except for Mahendri ma'am. Mahendri ma'am will give only in email because she's having throat infection, severe throat infection. She can't give it correctly. But with Dr. Priyadarshini Yonzon and with Miss Sheryl Salis, they both will address your answer, but it will be only for 10 minutes. So if you have, please, yeah. There is a question, can intermittent fasting can be suggested to diabetic patients?
You want me to take it up?
Yeah.
Again, I think intermittent fasting, if you see, I think it's become a fad now, Srividhya. Honestly, it's something that was practiced, I'm sure in your country as well as in ours, it has been in practice. There are certain communities who eat before sunset and they don't eat anything beyond that. But I think today it's become a very big fad. And I have seen people who are actually, they're using that 8 hours of feeding period and they collect all the food of the day and then eat at one time. So we do not know what is the kind of glycemic load at that point of time and what is going to impact the postprandial blood glucose levels. So we have enough evidence. And honestly, again, when if a person wants to do intermittent fasting, see, when a person comes to me and if I tell them that intermittent fasting is not good, today you have a lot of quacks out there who are promoting intermittent fasting. They will go to them and they will harm themselves. So might as well they do it with us in the right way. And today there's a lot of emerging evidence that if it is done under strict medical supervision, making sure that the drugs, because suppose the person is fasting and if the person is on insulin or if the person is on certain drugs which can cause hypo, then that person has to work with the doctor and the dietitian to adjust the diet in such a way and the medications in such a way that he's able to do it without any kind of hypoglycemia or any other complications. And still in that 8 hours of feeding, he still needs to eat right. I think that is the most important. The quality of calories and the quantity that the person is eating, very, very important. Because if you're going to exceed calories, you're not going to lose weight. Your blood glucose is not going to come under control. So it's not, again, a one size fits all. Even for IF, there are certain candidates who can't do IF. For example, somebody with a kidney condition, somebody who's on insulin, unless they work with their doctor, somebody who's lactating, somebody who's a pregnant mother, somebody with eating disorders. So a lot of people of those kinds should not do IF. And this is, again, not what I am saying, but the ADA guidelines were saying it.
That's really true part because many
publishing one of our papers on IF. So once it is, I will maybe share it with you and you can share it with the group.
Sure, definitely. Thank you so much. That was a really kind gesture. Like many clients ask to me, actually, we should not address our clients as patients. Generally, I don't address them as patients.
They don't like it.
Yeah. So generally they ask, what about intermittent fasting? What about ketogenic diet? Yeah, these are all there, but it is better not to follow these type of quacky things. If everything won't be fitting everyone. Intermittent fasting may be good for me, but may not be good for Sheryl and may not be good for Mahendri ma'am, or may not be even good for Dr. Priyadarshini. So it may be good for, again, Milanji. It may be good for Nani Shova ma'am. So it is always, it depends upon people. It should fit them. So Absolutely. It doesn't mean that if in case a Brufen is supportive to me, it doesn't mean that Brufen will be supportive for a person suffering from gastritis. The Absolutely. Same condition. It's an absolute thing. Same applies for drug also. Same applies for diet also. Diet is also a form of drug. So that is the main thing.
Keep it simple because then it will be sustainable. Follow something which has no expiry date. people want to do all this, but you'll see they'll be hopping from one diet into another and achieving nothing in return. Only more complications.
Definitely. So any more questions? If you have any more questions, please, you can.
I don't know whether they're allowed to ask questions. They can ask questions, okay.
Yeah, because I have made it as only host and co-host can see.
Correct. But at least, you know, what I try to do from my talk is try and expose you to what is happening. Don't get overwhelmed that, oh my God, you know, I don't know this, I don't know this, but it's important that we all know it because today there's so much of advancement. Honestly, there's so much, and our patients, like Srividhya said, we don't call them patients, but our people with diabetes and even clients, they know so much, and they come and ask you, and then if you sound clueless, you know, then a little bit, you know, they wonder that, oh my God, does she know enough kind? So I think it's very important that we know everything because, you know, there's so much of advancement in this field. And it's amazing. I'm telling you, this is the best phase to be in. When I started out 21 years back, I was thinking whether I did the right thing by becoming a dietitian because there were no opportunities. And the salary also was so poor. And that's why we didn't really have too many male dietitians. And today, the scope is so much. There's so much. And we're all looking at specialist nutritionists. In fact, in India now, we're having courses, master's programs, which have got bariatric nutrition, pediatric nutrition, renal nutrition, cardiac nutrition, diabetes nutrition. So, you know, PCOS nutrition. So it's all becoming so specialized. And it's great to see that there is scope for each one. And there's so much.
Yeah, that was really a very good chat and very good information from Sheryl. Thank you so much. With that, I think we can move into the next session. So next session, let me to lead this. Before even going into the vote of thanks, let me to complete this with certificate production. So I request our Milanji to just share the certificates. First, could you share the certificate for Dr. Priyadarshini Yonzon? Yeah, this one. So I now request our Vice President, Rashmi Bajimaya, Shrestha. Rashmi, ma'am. I will be just saying you can hand over to them. So after this, you can continue with your vote of thanks program. So this certificate, can you just virtually deliver it to Dr. Priyadarshini Yonzon? Yeah.
Okay, Namaste, Doctor. This certificate will be sent by your email very soon.
Thank you very much. And I'm so
Thank you,
impressed
Doctor.
with Miss Sheryl's presentation. Oh my God, talking about the latest technology and hypoglycemia and everything else. Your presentation was absolutely outstanding. I'm so impressed.
Thank you so much, Dr. Priyadarshini. It's a pleasure being with all of you and hope to meet you someday. It was lovely to hear you as well.
Likewise.
Next certificate, please, Milanji. Yeah. Before even giving Mahendri ma'am her certificate, she is a recipient of Citation of Honor Pioneering Contribution as a Faculty of Fellowship in HIV Medicine 2010 in CMC Vellore. Not only that, she was even Lady Legend Award winner from Saksham Society Jaipur 2020 and Inspiration for Generation Award 2020 from NNHSA Delhi. And also she even got Ideal Person of the Year 2020 under Health and Fitness section from Sajana Events Jaipur, and also Iconic Faculty Award 2020 from Saksham Society again, and also first edition of Ayyappan Quality Award Excellence in Nutrition Practice State Level Award by 2021 from Ayyappan, and also Foxclue's India's Top 100 Women Icon Award 2021 from FIPA. So with that, please accept our love from NDA, Nepal Dietitian Association, Madam Senior Dietitian Mahendri NV. Rashmi ma'am, please, can you just deliver it to Mahendri ma'am?
Mahendri ma'am, namaste. We will send you soon by your email.
Mahendri ma'am, are you there?
Thank you. My voice is gone very badly. You can't hear it.
Okay, ma'am.
Okay.
Thank you
Take
so
care,
much.
ma'am.
Please take
Okay,
care.
thanks.
Take care, ma'am.
Thank you so much.
Okay.
Next bit. Next slide, please. The final slide and the final award goes to Senior Dietitian Sheryl Salis. We are so much pleasure to know things about diabetes education, because our dietitians were so much interested to know about diabetes education. So definitely, it was really amazing. Even the new advancements about insulin pump, I only heard about that. I never practiced it. You know about the condition of Nepal. When Dr. Priya will be knowing better than me, because she's a consultant endocrinologist. We don't have practice of CGMS also. Heiner, Dr. Priya, we even don't have practice of CGMS. Do we practice in Alka hospital? Dr. Priya? Dr. Priya?
But Srividhya, honestly, even 2 years back, like I told you, we really didn't use so much of CGMS. But today it has really changed. I'm telling you, it's advancing so much, and I'm sure it's going to come to your country very soon as well. And it will be used in your country, because they're really looking at cutting down the cost. Cost is a factor. And honestly, it is the same in all our, in your country as well as in our country. But I think the more the number of people use it, it's the number game. Like I said, even SMBG used to be so expensive that today, because of the large number of people using it, the cost is coming down. So I'm sure even CGMS cost, and I'm sure there's going to be a lot of, let's look at it in a very positive way, that it will definitely work. But CGMS is really a boom. So if you all ever get it, I'm telling you, you will love it, because it really helps us help our patients do better.
Once I heard from Dr. B. Mohan, he was saying, like, even SMBG was very expensive. Yeah. And when the MR, medical representative, came, he said, the 8,001, can you make it as 800 INR, so that I can make all my patients to use it? Because 800 INR was easier. So that was the way the 800 INR wala SMBG was there. Glucometers.
I'm very happy to share with you that when Lifescan launched the Horizon, it was called the Horizon glucose monitor for 800 rupees. I had just joined the organization. So I joined them when they launched it. So it was amazing, because it was like a completely revolutionary thing to have something which costed 8,000 now at 800 rupees. And it was a really proud moment for all of us. And yes, it was Dr. Mohan's inputs that actually, got the company to think and work on it.
Yeah, there is a question for you, Sheryl, again. Like RDA of adolescent as per ICMR guideline, or if you can say how you balance their nutrition requirement, method use, since the person sometimes find the calorie is high, since adolescent nowadays are non-active.
Correct. So I think we have to use our own discretion. Honestly, we take a dietary recall, and that really helps to set the ball rolling. What is a person consuming? What is the quality of calories that the person is consuming? And then we decide how many calories to give. And then we, so basically the ISPAT guidelines. So for children and adolescents, we follow the ISPAT guidelines, which is International Society for Pediatric and Adolescent Diabetes. And they say around 45% of calories coming from your carbs, so 45 to 50%, 20% coming from protein, and the remaining 30 to 35% coming from fat, and concentrating on MUFA fats and omega-3 fats. So if somebody is consuming less, we wouldn't go up to 2,000, because we have also to try and bring down the blood glucose levels. So we will step it up gradually, but very important is to ensure that we're giving the good quality nutrients in terms of, the good quality carbs, proteins, and fats. And like you rightly said, our children are not active today. And that's a big, big challenge that we are facing. And I always tell them activity itself works like insulin. So please, if you want to eat that mango, make sure that you work out or you play. Again, exercise has become a regime, that's become another class. Parents are putting even children for classes for exercise. So they're not enjoying it. Whole day they're sitting online. It's still online in our country. And then after that, even your exercise classes are online. So, let them go down to play and enjoy. And I think that is a good thing to do.
Yes, thank you so much. With that, we are moving on to next session. The next section is actually the feedback and also the question quiz session. In this quiz, in the feedback itself, the quiz will be there. So to those quiz, you can give your answer. So who is giving maximum number of right answers will be giving the first prize of 500 rupees recharge in your mobile. So never forget with your mobile number, please give your mobile number. And then the second one will be 300 rupees recharge, and the third one will be 200 rupee recharge. So I request Milanji to just keep it in the chat. Can you just add those link in the chat, Google form in the chat? So you can do this, and you will be noted within 1 hour of the program. After the program, within 1 hour, you will be announced. The results will be announced in NDA page. And also with recharge, don't worry, that's a bonanza. Yes, with that, we are with the end of the session. In the end of the session, I request Rashmi Bajimaya ma'am. She is the Vice President of Nepal Dietitian Association. So to take over the floor, virtual floor, the floor is all yours. Please, ma'am.
Namaste. Good evening, everybody. We are very glad to have you all today's webinar on holistic approach for diabetes management and care. In this wonderful event, I would like to deliver heartfelt gratitude to our respected speakers. Despite of their busy schedule, they give us their time to share knowledge and experience with us. I take the golden opportunity to thank our first speaker, Dr. Priyadarshini Yonzon, for enlightening us on critical approach to diabetic management. Thank you, Dr. Priyadarshini. It will definitely help all new and as well as working dietitians in their practices. I feel more privileged to thank our second speaker, respected senior dietitian Mahendri and B ma'am. Thank you, ma'am, for sharing your valuable experience on diabetes management. Eating right is best partner for diabetes management. I also like to express my gratitude to our third speaker, dietitian Sheryl ma'am, for highlight the role of dietitians as a diabetic educator. Thank you, ma'am. And I would like to express my special thanks to Ms. Srividhya Raghunathan for moderating this event. Raghunathan worked hard on coordinating with our speakers from very beginning. Thank you, Srividhya. And I would like to thank Senior Dietitian Nani Sobha Sake, President of Nepal Dietitian Association. She has always been a source of motivation for all the dietitians in Nepal. Similarly, I would like to thank dietitian Vinita Panta for her effort to coordinating works. My thanks goes to all executive member of Nepal Dietitian Association, and I would like to thank Mr. Milan Dagal and Ms. Rosina Vista and John Club of Pokhara, technical teams for technical support and logistic management. And I would like to, at least but not least, I would like to deliver my special thanks to all participants. Without you, this webinar is not completed. Thank you all. Bye and take care and stay healthy. Thank you.
Bye, everyone. Thank you.
Thank you.
And have a good weekend. Bye.
Yeah.
Thank you. Thank you, everyone.
Yeah.
Bye.
Bye.
Bye, everyone. Milanji, it's shared to everyone, actually. It is shared with everyone, and even I have opened the chat. We can chat with everyone. So it's already shared with everyone.
Okay. Thank you, ma'am.
Yeah. Bye. Good night.
Yeah, I guess
Thank you.
recording can be stopped. Yeah.
Yeah, thank you, Srividhya.
Thank you, ma'am. Thank
Yeah,
you. Thank you for
wonderfully